Hi, I'm Dr. Margery Johnson. I'm a child, adolescent, and young adult psychiatrist with Potomac Psychiatry. And today I'm going to be talking about attention deficit hyperactivity disorder in the context of persons on the autism spectrum. In thinking about this presentation, I found myself reflecting on how things have changed throughout my career. Until the most recent edition of the Diagnostic and Statistical Manual, autism was actually an exclusionary diagnosis for ADHD, which means you could not diagnose ADHD in a person with autism, which ignored the obvious symptoms of inattention and hyperactivity in individuals on the autism spectrum. It also meant that insurance would not cover stimulant medication if the person had an autism diagnosis. So I was often in the position of having to decide whether the person's diagnosis would be autism or ADHD. So the most recent revision of the Diagnostic and Statistical Manual does allow for both diagnoses, which reflects the growing appreciation of the complexity of the autism spectrum and the possibility for coexistence with other conditions, particularly ADHD and anxiety. And it allows for more treatment options, which we suddenly need. Here are the diagnostic criteria for ADHD, which I suspect many of you are very familiar with, but there are all of these symptoms listed for inattention. Not paying attention, not sustaining attention, being easily distracted. Not seeming to listen when spoken to is one where there's obvious overlap with the diagnostic criteria for autism, which can be a source of confusion. But easy distractibility, losing things, being disorganized or forgetful are common criteria for inattention and ADHD. Hyperactivity and impulsivity is another cluster of diagnostic criteria. Fidgeting, squirming, running around, unable to play quietly, often talking excessively, interrupting others, or blurting out answers. Again, some overlap with autism spectrum. At least some of the symptoms have to be present before age 12 and present in two or more settings, like school, home, sports, or other community activities that interfere with the quality of functioning in those different settings. Typical presentations in individuals with autism. In thinking about this, I see two more typical presentations. One is the young child who could be preschool age, 4, or early elementary school. And these are kids who can't sit still and participate in group activities, which obviously has an impact on social functioning and social learning. These children can't pay attention to their speech and language therapy or their OT and PT, which obviously, again, has implications for an individual with developmental problems. These young children can also compulsively run off, which can certainly be dangerous and very scary. This is a child that bolts out of the schoolyard when the teacher turns her back for just a few seconds. Another presentation that I'd often see clinically is an older child in middle school or high school who has poor academic achievement, poor social skills, and particularly as they're moving into high school and maybe on to college, difficulty developing independence. They don't have the social skills or the organizational skills to facilitate the transition to high school or college or to the work world. There are several treatment options for treating ADHD. The most effective are the stimulants, but there are also non-stimulants and some non-medication treatments. So I'm going to discuss each of them separately. I'm listing the most common stimulant medications available. When I first started in child psychiatry, I believe there were 3 stimulant medications on the market. Now there are more than I can keep track of. These are the most commonly prescribed. Some are available in generics, some are relatively new and are still under protection and are only available as brands. Then there are more, it seems like there's a new one coming out every month. The stimulants are the most effective medications for ADHD, and as a group, they're all equally effective, but one might be more effective than another for a given individual. And again, they all have the same possible side effects, but a given individual might have problems with different side effects with different medications. The most common far and away are decreased appetite and initial insomnia, meaning difficulty falling asleep. Some children can develop tics. Younger children particularly are prone to become more irritable on stimulants, and headaches and stomach aches are also possible side effects. There are some differences between the different stimulants, and there are 2 most important differences. One is duration of action, and the other is how the medication is formulated. The stimulants come in short, medium, and long acting. The short are 3 or 4 hours, medium is 6 to 8, and the longest acting are all-day medications. And while again, this can vary, but this is just generally how they break down. And the choice of short, medium, or long acting depends on the child and what their needs are. A young child might need only a short duration of action, but a high school student with a lot of homework would probably benefit most from one of the longer acting medications. An issue that certainly comes up very often in individuals with the autism spectrum is whether they can swallow a capsule. So some of these medications can be either capsules that can be taken apart and sprinkled. There are some chewables. So there are a number of options that should make it possible to find a reasonable prescription for pretty much any patient. There are non-stimulant medications, basically 2 groups. Strattera and Quellbri are both reuptake inhibitors, which means that they act more like antidepressants than the stimulants. And the alpha-adrenergic agonists, which are former blood pressure medications that have found their niche in psychiatry. And I'll discuss each one of them separately. There are some problems with the stimulants. Some children with autism just simply do not respond typically to stimulants. They can become even more agitated. And that is a problem that becomes obvious immediately, but can be a major problem with this. Decreased appetite is also a big problem. A lot of kids with autism have issues with food related to texture or other issues. So a decrease in appetite can be a problem. Likewise, initial insomnia can be a difficult side effect to handle in children on the autism spectrum, because so many children with autism have difficulty sleeping. Tics can be difficult to distinguish sometimes from stereotypies or self-stimulating behaviors. Irritability is more common in young children or children with autism. Growth suppression is a question that often comes up, and frankly, it's not clear whether or not this is a real issue, aside from situations where the child's weight is so low that it would result in growth suppression. It is possible to manage side effects. With the appetite suppression issue, adjusting timing of meals, getting as much food as possible into the child during the time the medication is out of his or her system, increasing caloric density of meals, and they're loosening up restrictions about, bedtime snacks and such. If managing their diet does not help the problem, cyproheptadine can be used to stimulate the appetite. It's an antihistamine that has, as a side effect, increased appetite. Insomnia, obviously, is a big problem. And very often melatonin can be helpful, and clonidine at bedtime is also an option that is frequently used. People ask about drug holidays, and because stimulants do not need to be given every day to be effective. So if a child is having problems with appetite suppression or insomnia, taking some drug holidays, not taking the medication during the summer, gives them a chance to get a little bit of catch-up growth and weight gain. On the other hand, stimulants obviously have usefulness outside of school. It can be very helpful in allowing the child to constructively participate in social events, to be able to attend church, and to participate in sports. The stimulant can be quite helpful. And also, in terms of giving the medication every day, sometimes routine is simply preferable for many individuals on the autism spectrum. So doing the same thing every day, giving the medication every morning is sometimes helpful. The alpha adrenergic agonists are guanfacine and clonidine, and these are much more effective for the hyperactive impulsive component of ADHD, and they're less effective for attention problems. They have similar mechanism of action. In general, guanfacine is longer acting and less sedating. Clonidine is more sedating and shorter acting. So guanfacine is often more useful during the day, and clonidine can be helpful at bedtime. Both are available in shorter acting and longer acting versions, but guanfacine is the only one that can be given just once a day. The reuptake inhibitors are Strattera and Qelbree, and because of that mechanism of action, they don't take effect immediately. They also do not seem to be as effective for the hyperactive impulsive symptoms of ADHD, and there is very little research on their use in the autism spectrum disorder. Both are somewhat difficult in that Strattera has to be swallowed whole. It can't be crushed or sprinkled. It can take up to a month to work. That nausea is often a problem. Qelbree is a new medication that is still under patent protection, so there's no generic. It can be taken apart and sprinkled. So this may be a useful option. There are some non-medication treatments for ADHD. Executive function coaching could certainly be very helpful for older children, adolescents, and young adults to help them with organization and planning. There have been some recent studies about the use of micronutrients in ADHD, and they appear to be effective, but there is a smaller effect size than the effect of stimulants. And it requires the child or adolescent to swallow a very large number of capsules, which can be a major hurdle to deal with. Neurofeedback, which involves basically biofeedback, is of unproven benefit for ADHD. It's a very appealing, very interesting intervention, but it's not clear that its effects are generalizable to the real world as opposed to the neurofeedback world. External trigeminal nerve stimulation is a brand new technology that, again, is untested in the autism spectrum, but it appears to be a promising technology. It's a little gadget that the child wears strapped to his or her forehead and worn at night. And it does seem to have a significant positive impact on ADHD. But it'll be interesting to see further refinements of this technology and further testing. So, final thoughts. Each neuroatypical child is unique. Treatment needs to be symptom-focused. So, looking at specific symptoms such as inattention, hyperactive, and impulsive behavior is important. And that treating coexisting conditions can really improve overall functioning and quality of life. Thank you very much.